So we'll talk now about some of the other neoplasms. I'm not going to talk too much today about the odontogenic or epithelial neoplasms, although we will touch on one or two odontogenic related tumors. As far as fibromas go, these are very common. They tend to occur here, as you see, on the buccal mucosa, the cheek, between the molars. And these are related to usually trauma from chewing, masticating. They can also occur on the lip. If someone bites their lip, you get this reaction with hyperplasia and streaky collagen, often with vertically oriented vessels. You've seen these. These are not a diagnostic problem usually. There's another type of fibroma that occurs on the anterior palate. It has the same name, but a little different pathology because it has cartilage in it, and also may have nerve branches. Occasionally, in either one of these types of tumors, we can see very large giant cells, stromal cells, that have a little bit of atypia. But usually that's just a reactive process, not a cause to think of malignancy. There are some other lesions of the gingiva that are quite interesting. These four entities are probably related. And they're related in that their pathogenesis is similar. So these are probably instigated by some sort of trauma, from a rough food particle or from some other sort of injury to the gingiva that produces an aberrant response in the stem cells that are located there. And we'll look at these, but this should help to illustrate the reason why we have differing combinations and sometimes confusing combinations. But the important thing to recognize is that the behavior biologically of these lesions is almost always similar, low grade, and benign. So that's helpful. If you call it this and it's really this, it isn't going to make a big difference in either treatment or outcome for the patient. This is a chart that sort of outlines this. I'm not going to go through the details because we're going to talk about these individually. So morphologically, these tend to be red or have redness to them. And they're located right at the gingiva, usually on this keratinized portion, either on either side, on the interior or the exterior side. It just depends on where the trauma occurred. And these look very similar. Morphologically, it's very hard to tell pyogenic granuloma from giant cell granuloma from ossifying peripheral granuloma. So this is the most common. We see this very often. Typically has an ulcerated or granulating surface, and then a lobular architecture with dilated vessels. It's very common. The only real differential to consider is maybe other vascular neoplasm, a malignant neoplasm, or occasionally an entity called bacillary angiomatosis, which is very rare and related to a bacteria that tends to deposit in little dilated, in these dilated vessels and has a very granular appearance. So if you see something a little funny, maybe then think, but usually this is not a problem. As you can see, it can have normal adjacent squamous mucosa, which will usually be a little bit hyperplastic. Now, I want to emphasize this term here, peripheral. So what does peripheral mean? Outside, yeah. So this means it's outside the bone, okay? Doesn't mean it's on an extremity. It's not that peripheral. The mouth is really a central area, but it means peripheral in that it's outside the bone. And this lesion can have both bone and sometimes little things that look like cementum. So some people will also call it an ossifying cementoma. That doesn't matter which term, it's descriptive, and the behavior is very similar. Again, it tends to have some evidence of some trauma and regeneration, and then this very bland stellate stroma with areas of ossification and maybe cementum in there. Here, this also is a more ossifying one. You see this bone formation, surface ulceration. This is kind of like the reverse of a myositis ossificans. It's very reactive appearing bone. As long as you can verify that it's not in the bone, then you should be able to call it an ossifying, peripheral ossifying fibroma. So the X-ray becomes important here, to look carefully at the mandible, which is the more common location, some in the maxilla, to make sure that it is not inside the bone coming out. So on your cell phone, you have this tumor, the 3G. This is the giant cell granuloma of the gingiva. Another related entity, just a different morphology. You may have intact or ulcerated mucosa, and then you have everything that looks like a giant cell tumor of bone or giant cell tumor of soft parts, soft tissue. Many multinucleated giant cells, very normal appearing nuclei, similar to the intervening stromal cells. Maybe a few mitoses, that's okay, but not any high-grade atypia, no abnormal mitoses. So the differential diagnosis for these entities includes several other things that may have slightly different behavior. So for the pyogenic granuloma, an infantile hemangioendothelioma could look similar, but has a different age presentation, younger, and more aggressive behavior. The important one is the central ossifying fibroma, which would look fairly similar but have a very different X-ray appearance and is becoming outward from inside the bone. And then peripheral odontogenic fibroma. So this lesion looks polypoid and so forth, has a stellate stroma with some calcification, bone-like formation, and so forth over here, very pink. But it has two things that the ossifying fibroma or the cementoma does not have. And one is this odontogenic epithelium is present in the tumor. So if you see odontogenic epithelium that's part of the lesion, not just adjacent to, that's one clue. The other clue is that you have, this is not really bone, this is more like dentin. So if it has this fibrillar appearance like dentin, not cementum, then you should be thinking more of odontogenic fibroma. And this has it's usually treated fairly similarly, but may have a slightly different recurrence risk. Now this brings up other tumors, odontogenic lesions of the gingival area. And one is this peripheral ameloblastoma. So again, this term peripheral is important. It means it's external to the bone. It tends to be an adult onset tumor. And it has the typical stroma of a ameloblastoma. And the differential diagnosis includes the central ameloblastoma, so that's where the X-ray becomes important, and a few other lesions like basaloid squamous cell carcinoma. So one helpful, although sometimes subtle, difference is what's called the reverse polarization of the nuclei. What does that mean? Reverse polarization. Well, in a normal setting, the nuclei are basally located towards the center of the lesion or the tissue, tumor. In this situation, these peripheral areas have the nuclei central and oriented outwards a little bit. So that can be kind of hard to find, and you may not be totally convinced, but maybe right here you can see there's cytoplasm out towards the periphery and the nucleus is towards the center here. That's kind of what this is looking at. It's subtle, but knowing to look for it can be helpful. Other examples. Again, peripheral because it's not involving the bone.
So it is the characteristics of the peripheral ameloblastoma.
Okay, one additional odontogenic type lesion in this area is the peripheral, again this word, cystic or solid calcifying odontogenic tumor. So this has a little different appearance. We recognize that there is some odontogenic tissue here. So that's the key to this part of the name, is it has odontogenic epithelium. But it tends to form a cyst or have a slightly indented filled cyst type of appearance. And it has this unusual pattern of ossification or calcification that looks more like sort of reactive bone almost, but there's no real bony matrix there. So I have only seen one or two of these cases, and I have difficulty with them. So I would be going back to the books when I meet the next case like this as well. Okay, so there are other uncommon tumors, and I'll just touch briefly on one of these, and that's this ectomesenchymal chondromyxoid tumor of the tongue. So I've called it ECTT. There might be people who put the M in, EMCTT, into this lesion. It has a very interesting histology, I think, as you see here. It tends to be fairly cellular, and it has these cleft-like spaces. These are quite characteristic of this tumor. It has this almost chondroid type of myxoid tissue. So it has this chondromyxoid appearance. It isn't really known what this tumor derives from. It tends to have a fairly bland or low-grade behavior if it's excised. And it has this interesting phenotype of being uniformly GFAP positive, S100 positive, and Vimentin positive. but it's quite variable with other markers. CK sometimes, SMA sometimes, but no other epithelial or muscle markers. So this would be one, if you get one, to study and research, because I think there's still some questions about this in terms of where it came from.